Okay, good morning, everybody. We can get started. So, I would say in response to some significant dialogue that occurred yesterday relative to changes in funding for recovery programming, we decided to amend the agenda so that we could actually allow for as much public comment as possible. And so what we would like to do is, I have a couple of comments that I'd like to make, and maybe Dr. Alexander Scott does as well. And then we'll just open the floor to comment and have a dialogue. And then if we have time for the presentations, we will have the presentations. And frankly, if it takes the whole meeting to go through public comment, I'm happy to do that as well. And apologize to the presenters that we're going to do a presentation today. So, first and foremost, I recognize that we are all partners in this work, and we can only meet the challenges of this devastating overdose crisis if we work together. The administration is fully committed to supporting prevention, rescue, treatment, and recovery services for the long haul, and to identifying sustainable funding sources for all providers. Buddha and the state are currently assessing how to make funds available to the substance use providers impacted by these expiring federal grants. And as you know, I'm relatively new in my tenure as director. In fact, today is my 3-month anniversary. So there's a steep learning curve, but I am committed to making sure, or to trying to make sure, that we don't find ourselves in this situation again, that we do some planning so that we can handle this a different way and be able to manage the gap between one funding source and the next. And so, before we open it up for the comments,
Thank you. Good morning, everyone present here and with us on Zoom. We really appreciated the importance of the message that has come through to us for a number of reasons. One is certainly the content of the message and the fierceness with which advocates do your work and ensuring that we are addressing every element of our overdose and addiction response that we need to. The other important message is that while we have this venue and it's a model nationwide where we're able to have an interdisciplinary team of experts from across the state who are able to voice and support and advocate for and lead so many of the elements of the response that we have in Rhode Island. We value the relationship and the opportunity we have with the task force. And another thing that stood out to us is the notion that with the various elements of the working groups and the task forces that we have, there was some form of surprise with how the message came through, because we've had different interactions. We've been concerned by how the federal funding just stopped, and in spite of advocacy for more to continue, we've been attempting to figure out how to continue to fund what's needed and what's important. We wanted to make sure that perhaps the way this unfolded highlights for us the importance of shifting how we are approaching our meetings here so that we can preserve the time and protect the time to get that feedback and not have it be as much of a surprise as it felt, knowing the number of interactions and engagements that we have set up and in place for each other. So that's a big part of why we decided let's pause and use this moment to really get that engagement from you. Also hear what else should we be doing differently in terms of the channels of communication and how we can ensure that we are in alignment with tackling the things that we all have as a priority in place together to address. So we're hopeful that we'll be able to gain some of that from our discussion today. And we want to ensure that it's clear the support that we have together, with each other. We recognize that the providers are the foundation of our overdose and addiction response strategy, and we are committed to everyone's work being done as effectively and evidence-based as possible. So we want to continue to work together on determining what are the best strategies that are going to be most effective in achieving the outcomes we need to, and be able to evaluate those strategies and continue to target funding in alignment with what is going to be most effective. So we're going to shift over into opening our discussion today, and we're going to welcome Senator Miller to join us in appreciating your leadership in relaying the message and helping to ensure that it's understood and that we are able to move forward in a way that allows us to tackle both the issue of the funding as well as the process for engagement and communication so that we can continue to stay aligned. You want to come closer to get the mic? I won't bite.
So how did I end up here? I was invited because I felt it was fair once I got over the holiday weekend, input from many in the community who are providing the services that the funding has been somewhat in turmoil over the last few weeks. And I thought it was only fair to present some of the communication that was going on about the concern in the community, to the point where people felt they may not attend or may not attend in the future, or may curtail their attendance today if there wasn't a discussion that included many of those who were impacted. And therefore I agreed, once it was presented to me yesterday, that it was the wish of everybody who's spoken and others that we start off with a discussion to address the issues that were brought forward. And so I agreed to help facilitate that discussion. And I signed the letter and to start off by making it clear that I was with those who were concerned that where we are in the, as many in the Department of Health have described at these meetings, that we're in a syndemic, not a pandemic, and that what that has resulted in is a level now that has more fatalities related to overdose than it does to COVID. And that is an important thing to keep in mind as we discuss this. And we look at the resources appropriately that have been appropriated to addressing COVID. And then we look at the proposed funding for services that address the opioid epidemic and related crises to it, whether it be mental illness, homelessness, or other related issues, and the proposed cuts in the last few weeks to those services rather than increase in funding, as is described in the task force master plan, is that we increase the services rather than reduce the services. And so my concern also over the last couple of days is, well, funds are appropriated by the legislature. People have approached approach me, journalists or others around that, and I'm like, the funds that were presented to the legislature in June were not presented to include cuts to their services. And so I'm confident that most legislators, including myself and the Finance Committee, which I'm not on, did not anticipate these cuts. And so therefore, the most important part of this for me, and the letter, if everybody's seen the letter that went out, that brought this discussion forward rather than the agenda, is that we know there are resources out there, and they might not be out there right today. We know there are SAMHSA resources that are very recent to PDH, and Department of Health disposal. We know there are ARPA funding that needs legislative approval. We know there's opioid stewardship funds. And so I think the most important ask I would make from those who are able to disperse funds is that we level fund until we can gain and understand the resources and the timetable of those resources. And I know part of what we wanted as a discussion, at least what I understand what we wanted as a discussion today, is to hear from those who are impacted by the proposed budget cuts and their ideas on the impact of them and their ideas on how to restore the funding beyond what was presented. And I will tell you that who I heard from, the most important people I heard from, were not those who were writing the RFPs that reduce their funding, or those who sit at the desk in every agency, no matter how many people they have in that agency requires an administrative component to it. But the ones I listen to are the ones who were told, we potentially have a cut, and so you will be asked to do more for less or with less of you. And so I listened to those people and their concerns. They're almost panicked about this because they see in the last year and a half and moving forward more demand for what they do rather than less. And so they were really puzzled by what they were potentially being asked to do. So with that, I don't know how we want to start or organize input.
Do you want to go through the essence of the letter for those that didn't see it or see it?
So how many of you have seen the letter? Do I need to go through the letter? So the letter basically outlines all those services that may be cut by the RFPs, and the numbers add up, the best math that can be done by advocates and myself, and the numbers still coming in is a cut of service that is dramatic. Using recovery coaches in the ED setting, it's a cut of services from 24 hours to 12 hours. It's a cut of funding of at least 25%. There are several other components of the letter. Maybe an advocate, if they wish to, who is involved in drafting it, could go through it in detail. It's, but I think the crux of it is number one, where we ask for that we level fund until we know there are resources. We know those resources can't be delivered at this moment, but we know that everything has been discussed in the task force meeting historically for years. And I, like Dr. Alexander Scott presented, I go to other meetings with other legislators from other states, and they ask me, how did you get, first in the nation harm reduction legislation passed? How do you have this great coverage in hospitals? How do you have great coverage in prisons? And I always point to the governor's task force of how we got that done. So because this is happening at a task force meeting, doesn't believe I don't believe in the task force. I do. I think it's one of the most important bodies around these issues nationally. And so I just think it needs to be brought back to where it was and what the priorities have historically been demonstrated, not only by policy, but by revenue. So I don't know how you want to go forward. Somebody, Jonathan, and
Flip for it. Go ahead. Gentlemen. Gentlemen's first.
As expert advisor of the task force and having had dozens of conversations yesterday, I just feel the need to step in and make sure that everybody is heard. Josh, I don't know what's happening. You were sitting on this side of the table. Now you're on that side of the table. What's going on?
well, I couldn't talk
We had you over here, and now you're over there.
without me.
First of all, I want to start off on a positive note. What is this month?
Recovery Month.
What is it?
Recovery Month.
It's Recovery Month, right? So people do recover from addiction and mental health. And I'm a person in long-term recovery. I actually owe a debt of gratitude to Josh Miller because about 9 years ago, I was homeless. And I used to go over to the dumpster of his restaurant and take cardboard boxes out to sleep in at night. That is a true story. So thank you for housing me when I didn't have anywhere to live, Josh. You were doing good work even before I knew you.
And Jonathan, could you introduce yourself, so we'll continue that as the folks continue to talk as well.
To introduce myself, my name is Jonathan Goyer, expert advisor to the task force and person in long-term recovery. How many people are in recovery here? Look at, that's incredible, right? That is incredible. And I'm so proud. Having watched this development this week and watching how quickly the recovery community has mobilized to express their concern is just, I wish we weren't here in the context that we're here today, but it makes me proud because these are people that really care about their community and that do work every day. And these are the people why when we saw a 27% increase in overdose deaths and not a 49% increase like other states, this is the reason why. When we saw 3 years of projected decrease in overdose deaths, this is why for the people in this room. I understand the aggravation with this letter because a lot of people in this room that we're going to hear from today, they don't have anything to lose by walking out because they're not going to have a job come October 1st. So I understand the frustration that people are going through. And these are people that have been dedicated, task force members, dedicated to the strategic plan. And I just think it's really, I'm appreciative of pivoting the agenda today and talking about this. So for those of you who aren't familiar with some of the funding, with no objection, I want to just allow a few people in the room to stand up, introduce themselves, introduce their programming, and what's happening to their programming starting October 1st. Does that sound reasonable? Yes?
Yes. Yeah, that sounds good.
So I'm gonna start with the beloved Lori McDougall. Just 30 to 60 seconds of who you are, who you serve, and what's happening to your program on October 1st.
So I'm Laurie McDougall.
Hey, Lori, can I just one thing? I don't know if the people who are on the Zoom part of this can hear unless people come to the mic. Do we know if they're able to hear?
They're good to go.
Without people coming to the mic?
Yeah, we can hear loud and clear.
Okay.
So I'm Laurie McDougall. I started a program, a family program called REST, Resources, Education, Support Together, which is now the family program at RICARES. And it uses a very specific methodology, the only methodology out there that's evidence-based and focused on the family. It's called CRAFT, Community Reinforcement and Family Training. I do want to tell you that also we use this methodology, but also I personally have helped families to get their loved ones to the resources in the community that they need, all the different resources within the community. I've connected them to Anchor. I've connected them to the East Bay Recovery Center. I've connected them to the Parent Support Network. And in fact, I have done this as recently as 2 days ago. As of October 1st, my program is gone. That's where I'm at.
And Lori, how many, I know you do a family support group 3 times a week. How many people attend that just on one meeting on average?
On average, meeting attendance has been up. So between 20 and 22, and that's 3 meetings a week. So that puts us at,
That's about 250 families a month that are receiving support that Lori is single-handedly doing.
in this year alone, 94 meetings, upwards of 94 meetings. And that's just the meetings, because we do other things as well.
Well, I think regardless of the outcome of today, I think
So Lori, I'm trying to keep a running tab of dollars, so can you demonstrate the dollars in which it would take for you to go forward versus as of October 1st?
Well, I am looking to build up the program. I'd like to get, so I am being certified in the CRAFT methodology. I've been trained by Dr. Bob Myers, who created CRAFT, but I would also like to get other peers trained in CRAFT as well. And we would like to offer a program where families, and create a 12-week course, group intensive course for families to come and learn the protocols and the strategies and the skills in CRAFT. And then also have one-on-one coaching, as well as encourage people to attend the REST meetings. And we're looking at about $75,000 to try and to build up that program. And that includes the Family Task Force crisis toolkits that we create as well.
thank
Which
you.
we've given over, just to let everybody know, over the course of the existence of REST and through the Family Task Force, we have given out to families upwards of 1,100 family crisis toolkits, which is loaded with resources and information.
Nice. Thank you, Lori. I'm going to call on an old friend of mine, Holly Fitting, to talk specifically about, if you could just address the Anchor ED program and what Anchor Recovery Community Center, our beloved hero Jim Gillen, resided in his career, and just whatever you'd like to say about that.
Thank you for the opportunity. My name is Holly Fitting. I'm the Vice President of Addiction Recovery and Residential Support Services at the Providence Center. I, along with my fabulous staff, oversee all of the Anchor Recovery Center programming. I think many of you know that with Jimmy Gillen at the helm, 11 years ago, there was no recovery support services in the state. He spearheaded introducing myself, who had no idea what recovery support services was. I was a therapist. And he spearheaded the onset of peer support services within the state. He was relentless in his determination, and we started Anchor Pawtucket 11 years ago with Jimmy and half of a person, with no money, not 2 cents to rub together. I stand here today explaining to all of you, and many of you know this, Anchor is nationally known and now internationally known. Michael was on international news. Mike O'Neill, the manager of Anchor Providence, was on international Swiss news 2 weeks ago. So we are a nationally known program. We have serviced 27 US states on how we do what we do. We tell them the good, the bad, and the ugly. I've had the honor of working with many of you in this room. I'm sorry, but I am beyond words that this has happened. I had representatives from BHGDH come out to Anchor Warwick on June 23rd. June 23rd, sat with all of my managers and said, you guys have nothing to worry about. Everything is going to be funded.
And 2 months later, I get these procurements saying we are being cut $550,000. And you gotta make it work. That's what I was told. We were told in a meeting, many of you were in this meeting, do what you can. Do what you can. People are dying on the streets. Do what you can. I'll tell you what those cuts mean. My friend Zach Kenyon, tirelessly with Jonathan, came together to fund safe stations. Big initiative from BHTDH. Got a lot of press, nationally known again. Cut, we can't fund that. We were told from these procurements, oh, hub and spoke model. Good concept, sounds like a nice little title, hub and spoke model. These other recovery centers cannot support an ED program. They cannot support safe stations in their communities with the little funding that they've gotten. The Department of Behavioral Health and Department of Health and the state has been recognized as national leaders. This is a shame that this has happened. I've spent the last 3 weeks with my team trying to craft these procurements. That is a joke. People's lives are at stake. These people in this room there was no pandemic for us. They went out, put people in their cars, taking them to treatment, taking them to hospitals. The one thing that I will say is the Anger ED program cannot be dismantled. It is a nationally known program, it works. To have, with little to no notice, to have the other recovery centers say, here, you work it out with the hospitals. We can't fund it. We cannot fund this 24/7. Cannot happen. So if you check into a hospital at midnight, oh well, no peer support for you. This can't happen. And I know these leaders. There are many, many people at the Department of Behavioral Health. Dr. Alexander Scott has been a champion of what we do. And I know the federal funding, you only have what you have to work with. But I implore you to take a pause and let us work through what we have coming in and fund the programs, as Senator Miller said, level fund us until we can get have a discussion. We should not be cutting not one service in these times. It was far more than a minute. I'm sorry.
I know another program that is being slated to be cut by 25% is the wonderful East Bay Recovery Community Center. So, Tommy.
Sure.
So,
I'm Tommy Joyce.
up here so that they seemed that it sounded like they could hear before, but just making sure everyone speaks forward so that everyone on Zoom.
So my name's Tommy Joyce. I'm the Director of Recovery Support Services at East Bay Recovery Center, and it's true. So my funding was cut 75% at a small recovery community center in a community that never had recovery support services as of 2 years ago. So we're building. But, according to Holly, if we're going to be changing services, unfortunately, the landscape that we work in does not change. So we can tailor our services, we can reduce them, but there's still going to be a poison drug supply. There's still going to be people overdosing reported to the emergency rooms. There's still going to be families that are impacted, and there's still going to be fatalities. Again, in the strategic plan, goal 24B, increase funding for recovery community centers. So, we're a smaller center, but again, we got a short window. It's funny, I was on a fellows leadership working group with Mike O'Neill, with the University of North Carolina. And we were talking about some of the barriers that we have and some of the fears of our funding. And during that focus group is when I received the email for the procurement, and I looked and I saw my funding cut. So part of the conversations we've had was, one, can we level fund this until we can create a response and find a creative solution? After we had questions, we were given 10 days to submit a proposal. We didn't want a gap in services, so we had to put another proposal in for a 1-month budget, so we wouldn't have a gap in services. So that's a short window. That's a short reaction time. You know, and so we're encouraged to get third-party funding, other avenues for funding. But my question would be, is the state doing the same? So, you know, usually when something gets taken away, something gets brought to the table. So I've been asked, you know, can we look at the Medicaid billing for peer recovery support services? You know, we don't have telehealth when COVID hit. No, but we're still doing the services. My staff was out there on the phone every day, connecting with people, making sure we're available. And, you know, can we look at some of the Medicaid billing, because we do specialized peer recovery support services. So if somebody is in a health homes team, they might need extra help, which we provide. We don't get funding for that. We just get funding for a face-to-face encounter, and that's a minimal rate on top of that. So if we're going to get cuts, something should be brought to the table for us to kind of create a mechanism for us to kind of create some revenue. You know, because when everything happened before, every other behavioral health program, the telehealth services was funded, except for the peer recovery support services. So I always say that, you know, the task force, you know, there's people accountable to the task force, but us in the recovery community, we're accountable to our community. And our community deserves an explanation if our services are going to get cut.
I know.
John, I know that John Tassoni wanted to speak, and I also noticed that there are a lot of people in the chat, and so I can't read the chat, but there are also hands raised, so at some point we probably want to go over to that.
We can do that after John.
Yeah.
Okay. Well, I mean, go ahead. Go ahead, John. The meeting's been taken back, I guess.
No, you can do whatever you want. I'm not
No, don't tell them that.
Yeah.
I just want to say, Director, I'm very pleased to hear you say partners, because before, all of us in this room were considered vendors. And I think what we should do as a group is have a group of people in the community help make the decisions, not just in the departments, because we are all boots on the ground. I'm not taking anything away from the staff that both you have, but you may not be getting the information that is needed to make informed decisions. Now, my phone has been blowing up since Senator Miller sent that letter out, because I represent 31 agencies, and a lot of them are in this room, have been cut, and it's not right. As Senator Miller said, we should do a pause. We should make a decision today. Time out, everybody's on hold until we can meet, discuss it, and try to figure it out. Because when you have decisions like this being made in a vacuum, and then all of a sudden it leaks out, this is what you end up with. A catastrophe. That's all I got to say.
Mike and then Colleen.
Hi, Mike Rizzi, a long-time person in the addiction treatment field. And one of the things that I'd like to comment on is that when this task force started, we were considered partners. And when you have a partner, one of the things that you want to do is to make sure that your partner is protected, that your partner has status, that your partner is respected. And my sense on these developments is that there has been no respect for, there's been no acknowledgement of the importance of the partners in this project. If the partners who are in this room were not part of this task force, the successes that this task force continues to say it owns would never have happened. You cannot take a look at dismantling your partnerships without understanding what the unintended consequences are going to be. And I have a feeling that no one sat back and said, what's going to happen if we do this? No one asked anyone the question, if we do this, what will go away? Just because we have a process that acknowledges, and with all due respect, overdose is just one element of the universe that we're dealing with here. Overdose is the symptom. The partners have been providing the solutions. And I think when you disable and disenfranchise the partners, you're making a terrible mistake. It's going to come back and it's going to bite you. And the partners are going to be here saying, we told you so. But at the same time, the partners are going to continue to make as much of an effort as they can in spite of what you're doing. Because that's the commitment that the partners have. So if you want to have a successful, integrated, productive, respectful, and responsible response to the overdose crisis in Rhode Island, if you leave the partners out of this process, it's not going to happen. It will not happen. And you'll see all those things that have been going away or that have been improved on going away. There'll be no resources. There'll be no capacity.
I'm trying to keep a running tab of like what we're asking for in dollar amounts. And so Tom, you brought up Medicaid codes and your cut or your defunding it. So I just, if you could quantify that, and if anybody else has a Medicaid issue that they can quantify, can they please do that, just so we can keep our running numbers total here.
And I think that it was 75,000 cut from
It was there, but it was also, you know, we had the opportunity to reach out for outreach, which would actually bring more people into the center. And we got a 6-month funding that we kind of carried over for 95,000, but that's only for 6 months. By the time you get somebody hired and on the street and up and running, that's over. So, you know, with 75 plus another 180 to carry a 4-person outreach team, that would be in the community that's out there. You know, and that's also, that outreach team is also a funding source because it brings referrals into other recovery centers, which can be possible billable services. So outreach is a main component, too, of this. You know, if you're going to give us a chance to have any type of billable services, these outreach, one, it's crucial because people got to meet people where they're at. That's the utmost. But also, you're going to look at it too as a referral source that we could actually bring into our centers as a business model and have billable services on top of that. So, you know, it's you know, you look at for what we have, it would be 180 for the outreach plus 75 that was cut for our center that would actually provide those billable services.
And you had a number for Medicaid?
So the other issue with Medicaid billing is that the anchor, again, was on the forefront of Medicaid billing. We've been billing for probably 7 or 8 years. We were the first, I think, one of the first in the nation to be able to get peer support reimbursed. When the department switched over and got the waiver, now we have to send, it's a carve-out now for Medicaid expansion, so all the bills get sent strictly to the Medicaid office. Since then, anyone who is associated with the health home team gets denied. So for those of you, many of us, we have no idea who's on a health home team or not, and it's a separate service. I have been working with the Department of Behavioral Health since January trying to fight this fight to say it is a completely separate service. Somebody comes into Anchor, they meet with Mike should be able to bill. They also have a health home team at Gateway Healthcare. It's a different peer for behavioral health. And we have gotten thousands of dollars in claims for services rendered denied. So the sustainability model, it's fabulous if we can bill and get reimbursed for it. We've never had any issues before with billing straight to the plans. And ever since the Medicaid office took over, and it's been relentless. Your staff are wonderful, I will tell you, but their hands are tied as well. They've been trying to help me to access whoever I need to access at UHHS, but it's been months and months of nobody knows, nobody has time, nobody wants to hear it. So we stopped billing.
Are you able to quantify that?
Are we able to quantify that?
Yeah.
I bill probably around $10,000 to $12,000 a month, so it's been months and months of it, of not being able to bill. So over 100, well over $100,000 that wouldn't have to be paid through contracts. And I'm sure probably even more than that, because we were the first ones to do it. So the other centers are able to bill as well, as long as they get paid for it. And it's a lot of overhead, it's a lot of time with billing, only to get claims denied.
So back to...
Excuse me, is Senator, this is Linda Hurley. Can you guys hear me?
Yep.
Okay, great. I just wanted, when you're talking about quantifying, Kodak received a tremendous amount of cuts to us. We're a small organization, so in 4 areas we received cuts. Now, quantifying them, the first cut that we received, just on the top of the list, they all came about, one came 2 weeks ago, which is really a very short period of time. Apparently, the reason for it was somebody had it in their draft box and forgot to send it. So that one was for $700,000 was forgotten in a draft box. So what we have been providing for BH Link 24/7 urgent care for on-site inductions for buprenorphine and referral within 12 hours or less for methadone, for MOUD, for opioid use disorder, as well as providing medications for other substance use disorders. We have a doc on call, we have a nurse care manager. Also included in that amount of money was also weekend work and nighttime work for, as Holly said, Kodak is internationally known for our medication-assisted treatment for the ACI, and internationally known for how we connect people upon re-entry into the community. And these are services that begin the re-entry into the community, often begin at BH Link. So that program was totally cut. We don't need that much. We can move things around in terms of how much money it would take to continue, but at a minimum, it would be about $300,000 to $400,000 because we have the physicians on call at BH Link to do the telehealth. We also, if you may know, that we began a mobile unit, 37-foot medical unit, about 3 years ago. That was funded for $300,000. The unit, we had some trouble with that unit, and so we, due to the generosity of the Champlin Foundation, we have our own unit now. And we were so excited to finally be able to get the pilot done because what we were going to do was measure how many billable services it would take to try to keep this mobile unit sustainable. And especially now when we're looking at people not wanting to go to the hospitals and they don't want to go to central spots. So we could go out to those areas of disparity, and we know we have them, whether they're rural or urban, and meet that need. And again, we are now not being funded for that staffing for the pilot. So that would be, about $300,000 or $250,000 a year. And we see, in this particular case, we would see almost 100% Medicaid. There were some other things that the Department of Corrections actually picked up for us immediately. With the store dollars, but the mobile unit, the mobile treatment unit, looking at the disparities, looking at getting into those neighborhoods and being treated by those neighborhood, or by by individuals reflecting the neighborhood demographic is absolutely critical. Our new van is going to be ready to go October 15th, and we can't staff it. So again, and it was without any conversation at all. No one spoke to me or others about, I figured it was claims, invoicing, that must have been the data that was used. And I beg everybody to remember that it was COVID. So thank you again, Senator. I really appreciate it. And for those of you, my name is Linda Hurley. I'm sorry. I'm the President and CEO of Kodak Behavioral Health Care. And this is really heartbreaking to me as well. I really have trouble understanding it. Again, the only way I can't understand it, because you can see that we've been recovering since January and July of this year. So I thank you, everybody, for your time. And is that what you want? Is that the kind of dollar number that you were interested in, Senator?
As people speak, I'm just trying to get a dollar amount, so when we talk about level funding, we know what the target is on that. And I just want to correct people when they talk about the letter I sent. Is that I sent a letter that was presented to me in time over the Labor Day weekend. So when we had a meeting on Wednesday, today, that members of the task force, especially DHPDH and the Department of Health, had time to respond to it. It's not my letter, it's my forward of a letter. And I did advocate for some changes, and some changes took place in it, where I identified the concept of level funding, targets that were indicated in the letter.
So I know there's two more people in this room that are directly impacted by the cuts from BHDDH. First would be an organization that saves an incredible amount of lives, Project Weber Renew. I worked for Project Weber back in the day. When I was handing out naloxone at Project Weber, 17.6% of the kits I handed out were used to save a life. It's incredible the work that they do in the community. So, Colleen.
Thank you so much, Jonathan. We're about up to 25% right now, so we've even gotten higher since the time when you were with us. So I'm Colleen Daly-Ndoye. I'm the Executive Director of Project Weber Renew. I'm really happy to be here. I'm grateful to everybody for calling this meeting and to the state for the response. I think we're in a really urgent moment, and we're at a time when overdose deaths are up, and the investment should be increasing rather than decreasing. We're a boots on the ground organization, and we're alongside all our partners here in recovery and harm reduction. And I can say that our staff people, many of whom are in recovery themselves, were already struggling before these cuts. So everyone here, like they all said, we're going through the pandemic like there was no pandemic. Everyone worked the entire time. So there's a sense of we've made it to this point through the pandemic, and we're getting beaten down essentially again. So the two things that in the letter that I really wanted to focus on was transparency. The budgeting process and the reason that funding goes to one organization versus another, where the funding goes, how much it is, what are the timelines, that is never clear. That is something that we as community partners need to know. We need to understand, where is the funding going? How long does it last? How do we know that we're going to be able to plan? We hire people, we lay them off. The impact on the people, especially people who are in recovery, to be hired and then laid off is enormous. It is horrific. So that's first of all, transparency I think is absolutely critical for small community-based organizations in order to plan. The second thing is that we need to exert significant pressure on the legislature to come back this fall. I recognize that BHDDH's funding is a significant portion of a lot of people's budgets and Department of Health funding. But there's other additional funding that we should be pressuring the legislature. We should be pressuring them to come back and to get a designated funding stream for Narcan. We should be pressuring them to come back and to designate funding for a lot of these critical infrastructure for recovery. We're seeing overdoses going up. This should not be something where we have grant piecemeal jumping from hoop to hoop. We should have a dedicated funding stream that is the foundation, and then the grants should be used as the additional. You try a pilot, you try something, it doesn't work, you have a grant and it goes away. But there should be a foundation of funding that all of these small community-based organizations that are absolutely killing themselves out there every single day should be able to rely on in order to be able to survive. Thank you.
We're fortunate to have 6 recovery community centers in the state of Rhode Island, far from the back when there was one in Anchor and Pawtucket. Right now we have 6, and one of those is the Serenity Center up in Woonsocket, which is overseen by Community Care Alliance, who is, if they weren't there doing this work, I can't even imagine what the community of Woonsocket would look like right now. So, Michelle Taylor?
Thanks. My name is Michelle Taylor. I'm the Vice President of Social Health Services at Community Care Alliance. Our budget cut was $75,000 this year. During the pandemic, as everyone did, we continued not only to operate our existing Serenity Center, but the need was so significant in Woonsocket that we opened a new center during the pandemic. We opened Safe Haven, which is primarily focused on homelessness and harm reduction. So we are literally seeing 50 to 70 people coming through our doors of both centers every single day. We've been very fortunate that we were able to get some supplemental funding through our HES, but that brings the water line just to like under our nose, right? That doesn't that barely brings us to break even. And so we can't, even though we've expanded and we're seeing several hundred people more than we were doing last year, we are having to do it with less staff. On Monday, I responded to, on the holiday, as a vice president, I responded to an emergency, a client emergency in the community, because I do not dare call my staff to ask them to do yet another thing. When I lay my head down at night, I am terrified of thinking, who is going to call me tomorrow and say, I'm done. I cannot do this work another moment, right? The problem is there's not enough resources. You have someone in front of you who says, I'm ready for detox. You call, no beds, sorry. I need a roof over my head, sorry, call CES. Nope, no room, no shelter. You're gonna be on the street again tonight. You can only take that so long before you say, I can't do this again. I cannot get up out of bed today and face another person and tell them, I don't have the resources for you. I have no place for you to go. Yeah, but here's this phone call. Fine, what does that do? I'm still sleeping on a rock tonight. That's not okay. This is what we are dealing with right now. And not only are people dying, our staff are just at their breaking point. And I can't be a silent witness to that. We have to speak to it. Thank you.
I think, because we've been doing it for 57 minutes now, so I know there's 2 or 3 other people that want to speak. And people on Zoom, Zoom land.
2 individuals on Zoom.
2 on Zoom.
Karen Jeffries.
So maybe if we could keep it to just 2 minutes each, and then I know that ultimately everybody at the end of the day wants an answer of the question of whether or not there's a commitment from the HGDH to level funding until we can identify additional resources. That's why everybody's here, right? Zach.
Good morning, everybody. My name is Zach Kenyon. I'm the EMS chief for the Providence Fire Department, and I am heavily invested in all of you and safe stations. A few things I've learned is that long-term recovery is day-to-day, and long-term recovery, you need employment. We're about to uncut employment for numerous people in long-term recovery, saving other people seeking recovery. That to me is disastrous. I've read twice in the Providence Journal over the last 6 to 7 months about state surplus. One of them being federal COVID money. If everybody in this room has worked through COVID, why can't we use some of that money to fund what we're doing, right? Colleen's point, we need to start a fund here where we can subsidize the federal grants. One of the ideas of billing through Medicaid, think of the millions of dollars the state will save if we can let Mike O'Neill bill for $50 versus going to the ER for $2,000. If we could take all that savings and put it into a fund to now start sustaining what we're doing here, right? Overdose deaths have gone up. Everybody knows that. People are isolated. The pandemic's not going away, right? We're requiring everybody to get vaccines. Everybody in here is wearing a mask. It's not changing. So we need to think of ways to start saving lives, and we need to invest in Rhode Island's future for saving lives. I'll just let you know, my station signs are not coming down October 1st.
Do we want to do the two on Zoom?
Yep. Karen Jeffries and then Amy McCarthy.
Great, thank you, Director. Hi, I'm Karen Jeffries. I work at Horizon Healthcare Partners and BH Link, and Senator Miller, just wanted if we could add to the list about the mobile crisis. So we were awarded a grant with Community Care Alliance, Dave Michelle Taylor, Gateway, Amy's getting ready to speak after me, Newport Mental Health, and Thrive to do mobile crisis. And as everyone has said, Linda Hurley, thank you for everyone, Jonathan, thank you everyone, Tommy Joyce about the outreach that everyone said. It's not going away, the problem's not going away, it's only going to be more. And then just want to remind folks, in a year, 988 is going to go into effect, and that is going to be required to have a mobile treatment part of it. Call, text, obviously BH Link, walk in to the Community Mental Health Center. So Senator Miller, if you could just add to your list, your running list that you have, that come October 1st, we will lose the SOAR mobile dollars that has funded mobile crisis in every city and town in Rhode Island. And Amy, I know Amy is one of our amazing clinicians out of Gateway who covers like half the cities and towns, so I'll let her talk directly about what's going to be a loss for them.
Thank you, Karen. Yes, my name is Amy McCarthy. I am the lead clinician for the SOAR program through Gateway Healthcare. A couple of different things. So right now, my agency is able to provide 24/7 response to a community crisis if we are called out to do that. We are able to do that because of the SOAR dollars in our per diem pool. As of October 1st, when our grant ends, that coverage goes away. I was told about this on August 2nd, and since that time, I've had probably about 5 different police departments reach out to me to find out what they need to do to get a clinician on site, either per diem or full-time. I've had multiple departments ask me about trainings, and these are all things that we provide under our SOAR grant that we won't have. The response from the police departments has been overwhelming. They love having us here. They love having clinicians on site. Just like we need our peer recovery specialists, to have a clinician to go out when someone's having a behavioral health crisis is beyond measure. And I apologize, Senator Miller, I am not a numbers person or a finance person, so I can't give you that, but I can get you in touch with the person who can. But just even the thought of this program ending just seems not okay, especially in this climate. I came in today with about 4 different messages of people that I need to follow up on, and we probably hear daily, if not like 3 to 4 times a week from Gloucester PD, which is so small, but yet they constantly need a clinician to go out and to respond to behavioral health crises. We also provide officer wellness, something that kind of gets neglected. So this is something that I'm very passionate about and I want to continue to be able to do, but without funding, without continued sources, it's down to just me and one other clinician, and we can only respond to so much. And we cover a lot of areas, so.
So I know there are a few others, but I guess we'll end with the sort of the lead advocacy organization in the state of Rhode Island, which is RICARES, and RICARES has been around for how long?
20 years plus.
20 years plus. So Ian?
Good morning. My name's Ian Knowles. I work at RICARES, and I'm a person in long-term recovery. 90 minutes to address the multiplicity of issues and far-reaching effects of these cuts is simply not adequate. The message that we have received, despite your introductory remarks, is that we are being minimized and patronized. I've been very angry since Monday, and I'm trying to be civil, and my intention in coming here today was to come and walk out, and I'm not, because I'm looking for a more constructive solution and action. It's simple to identify the state's priorities. It's not reflected in what you say, it's not reflected in what you promise, it's reflected in what you fund and what you don't fund. The affected programs and the initiatives are all linked to the task force strategic plans of the last 4 years. The cuts significantly weaken the recovery pillar. The rescue pillar is teetering now due to your continued lack of action around implementation of the repeatedly stated rescue goal in the plan to develop a plan for funding rescue resources, including naloxone, which was reiterated in Goal 9 of the recent update to the strategic plan. Find and ensure sustainable funding for naloxone. We don't understand the governor's decision to cut this funding. We have no idea where the millions of dollars of SOARS funding has gone to. We need, to echo Mr. Tassoni, a decision today. We don't need more ongoing assessments. Thank you.
Hi, I'm Dr. Susan Sordi. I'm the president and CEO of the Stewardship Council, which represents at minimum 31 organizations throughout the state of Rhode Island providing a variety of behavioral health services. I'm going to keep this really simple. We have a strategic plan that does not align with the current infrastructure within the community. The infrastructure of behavioral health care services were designed decades ago as a chronic care model. We're consistently using it because of issues outside of our control as an acute care model. We're not taking into consideration that the demands placed on the workforce are significantly different than they were even 2 years ago, that the individuals presenting for services look very different, that the individuals who are receiving recovery services come with a multitude of other issues as well. Many of the needs that they are in need of, unfortunately, don't exist. And the reason they don't exist is because at the time the network was structured, those were the top priorities. We have a strategic plan. But when you align that strategic plan with what's available in the community, they don't work. You have a multitude of resources and expertise in the state of Rhode Island, yet we very rarely call upon it. I, like others, say to you, please work with us as a partner. Let us help you design a system that meets the needs of the people who are looking for services, while at the same time taking care of the workforce, because right now, our concern for workforce is as much as our concern for clients who need services. We're losing workforce across the continuum, not just in behavioral health, but healthcare in general. If we could come together and begin to assess the funding that's available, I will tell you that at one time I had a conversation with individuals at EOHHS, and to my surprise, I was told one client had 11 different caseworkers asking the same questions over and over and over again. Why? Why are we not looking at how do we utilize those resources differently and maybe shift them to the resources that are needed amongst the recovery centers and other initiatives? There are so many needs in the state, and I do believe that we have to become very creative, think outside the box. And I know that we have the expertise and the experience to do that. We're just never asked to come to the table. So please consider that as we go forward. Thank you.
I just have three more quick points to bring up from concerns that I've heard in the community. There's obviously a mechanism in place to find money and fund things because, as we were here last month, Linda Mahoney and a staff member from the governor's office presented the Amani Breakthrough Project. This is something that nobody in this room had really heard of before. Nobody was really asked whether or not that's something that we should fund as a state. They were awarded $880,000 over the course of 4 years through SAMHSA block grant money. I'm all for the concept, and I know a lot of people in this room are for the concept of the Amani Breakthrough Project. That is a high dollar amount to hand over when these people who have been working for 6 years on this task force are losing funding. That is nobody in this room got a vote on that. They were told that's what the state's going to do. That's something worth taking a look at. Who made the decision to do that? How does the procurement process work at BHCDH of what, as Ian said, who gets funded and who doesn't get funded? Who's friends with who? Who knows who, right? Who's connected with who that's getting funding? That's something to really consider. The second thing I want to bring up is the Opioid Stewardship Fund. I've been bringing this up for a few task force meetings now. The two co-chairs of this task force are in charge of a fund called the Opioid Stewardship Fund. This was a bill that was passed in 2019. I'll give you the 10-second version that effectively taxes opioid prescription manufacturers in the state of Rhode Island. It's attuned to $5 million per year that is supposed to be allocated for treatment, recovery, prevention efforts. That has never been brought to this task force. As the two chairs, I look at, with all due respect, Director Alexander Scott and Director Charest, you are in charge of this opioid stewardship fund. There is no mechanism in place for these people to ask for funds from that money. This year, legislatively, you've only allocated $2.3 million. Where is the other $2.7 million going? Why aren't we using that to fill these gaps, right? That's something that we need to take a look at. Where did the money go last year and what were the specific outcomes? And who made the decisions around those outcomes without including people in this room? Your 40-plus dedicated task force members, hundreds of people that attend the work groups. That's something that's a pot of money that is underutilized by this body of people. And as far as I'm concerned, this task force and its members should be fully in charge of that fund. Another thing to note for those of you who are not aware in terms of SAMHSA block grant dollars, in 2020, substance abuse treatment alone was awarded $21 million. In FY22, it was awarded $29 million. The total discretionary allowance for SAMHSA block grant money in Rhode Island went from $33 million in FY20 to $55 million in FY21. I don't know where that money is. That's something worth taking a look at, I feel like, because there is money. There is money laying around, as we found it for the Amani Breakthrough Project, right? So, for me, I think in reading this letter and supporting my community, I think for today, it boils down to one question, is the state, particularly BHDDH as the primary funder for these activities that will not be here 3 weeks from now. You want to talk about a task force meeting next month, these people aren't going to have a job to come to the task force meeting for. Is the state willing to publicly commit today that no funding will be cut come October 1st? And that we will sustain funding throughout FY22 at the same dollar amount if not higher. For the sake of time, this is a yes or no question.
Is that a motion?
That's a motion for the community.
Because I think we also need an answer. Do they commit to having a group sit down at the table and discuss what's going to be spent and what's not going to be spent, instead of making in-house commitments without the provider group at the table?
I do want to support that a lot. I think part of the issue is that people do not know what happens, and really the sunlight on the funding process. Transparency to the funding process would go a long way in building trust.
I also think that perhaps we are a task force. I believe we may have the opportunity to make a motion on what has been said. And if nothing else, if we cannot make a motion, perhaps we can ask for a show of hands that supports the positions that have just been put forth.
Well, so let me ask everybody this. If your answer is no to that question, how many people are going to walk out today? Choose wisely, sir.
So, first of all, I want to thank you for sharing all of this information with me. Many of you I've just met for the first time today, and so I appreciate that. Many of you have reached out asking to meet with me, and I always meet with the people that ask to meet with me. I will pledge to you today that I will ensure a transparent process. So I will do that going forward. I am very much in favor of transparency. You've raised some questions that I can't answer for you, but I will look into them on how fundings were allocated and things of that nature. I, like many people in the room, saw the letter for the first time on Labor Day at 10 o'clock at night. And so I've had one day to try and determine how I'm going to respond to your additional funding requests. And I know you would like me to have an answer for you to level fund everything, but to be responsible about this, and I would love to do it in conjunction with people that are volunteering to help me analyze this. I've begun the process of trying to find additional funds so that we can make that type of a commitment, but I'm not there yet. It's not that I'm not interested in doing it. It would be irresponsible of me to commit something that I don't have dedicated dollars to do. And I don't want to start off my tenure as a member or the chair of this, co-chair of this committee, making a representation that I can't deliver on. But you have my promise that we will work very, very hard to get to that point in conjunction with you. And so to John and to Dr. Storti and to you, I would invite you to come and meet with me and talk about this and evaluate the numbers and the dollars and what's available so that we could do it. I know one of the things we're trying to do through the procurement process is to transfer the funds into a block grant mechanism so they can be reliably funded every year. And we're not going through these funding cliffs that we're going through right now. So we had an enormous amount of money for 2 years that was cut much further than what we were able to reprocure, but we were able to convince them to restore some of the funds. It's still not enough. We do need to find other sources. And so we are actively in the process of trying to find sources to make that up. I don't, unfortunately, since 10 o'clock Monday night, have an answer for you today. I will have an answer for you before the next meeting, because I recognize that the funds run out on September 29th, and the next meeting is in October 13th or something.
So what's...
Can you just give us a hard date other than before the next meeting?
Ryan, I'm calling on my staff to help me try to give you some a reasonable answer that we can achieve.
September 15th?
So that is
a week from today.
A week from today.
Are we having another meeting?
Well, I think it would be very important for a smaller group to get together and have that dialogue, John. I mean, I'm happy to have another meeting, but I'm hoping that working with a smaller group, we can put our minds together.
Their concern is that the new scenario is 3 weeks away. And so that's where we're at.
For an answer by the 15th. That's not.
And I think that's why, we've got, an hour and a half of dialogue or an hour and 40 minutes of dialogue, and then, and then what we have now. It's because of that. It's because of that. And they, a week to them, the 15th is, for those who are part of government, it's lightning. But to those who are not, it adds to the panic. Yes. I know.
I'm totally going to take the date because everybody, oh my God, everything aligns perhaps.
Yeah.
But I'm feeling urgency.
Yeah.
We all feel that urgency.
Yes.
Because we need to respond to it.
Yeah.
So the goal was to
And I will
listen
tell
today,
you-
and we listened. We
and I
have
will
more
tell you-
information, and we need to get back.
Yeah, and I will tell you that the legislature, at least for me as a legislator, they didn't anticipate these cuts. Nobody told us that we need more so these kind of cuts don't happen. Nobody said that through the budget cycle, okay? Nobody said, by the way, in October, services are going to be cut by 25%. Nobody, as far as I know, told the legislature that. Nobody at SAMHSA, right, was told, we haven't figured out how to spend the money you gave us this year in order not to have these kind of cuts. To me, that would be a concern at SAMHSA. Those who passed the opioid stewardship funds, right, in 2019, with the intent of them to increase these kind of services rather than decrease these kind of services, would be concerned, or probably are concerned based on what would happen. And the ARPA component of it is after October. I am pretty confident that based on the Delta variant, the legislature is not interested in coming back in September. Okay? I think they are interested in coming in the fall, but it would not be September. So that does not help this issue.
Yeah, but that's why a solution immediately is going to be necessary. We do have flexibility in terms of funding that we can look at, having a clear understanding of what's the dollar amount of the cuts, which I couldn't get because people were talking more about not just level funding, but expanding.
Yeah.
But I think BHDDH knows that because BHDDH issued those notes. So we can review that, look at the funding that we have available among not just BHDDH, Stewardship Fund, Mackenzie Settlement. We have
This is
other
it's also a
funding
COVID
streams we
issue.
can look.
And I talked to
that's what I'm
Congress,
saying, right?
I talked to Congress the
Including
other
funding.
day. They're trying to figure out how to spend COVID money, right? It should not be siloed. The solution should not necessarily be siloed. Exclusively to BHDDH or DOHHS. It should not be siloed.
So, but we need to be getting a clear sense of where we are with all of that information, so having that will be helpful.
Yeah.
And maybe we can reconvene at the end of the day, if you guys have that information, and talk about next steps.
And in the meantime, we have our standing meeting in 30 minutes. I will do my best. I want to thank everybody though, and everybody who knows me, and Dr. Alexander Scott, you know I was HES, so I'm all about health equity too, right? I'm a peer, so I want to thank you, and I want to thank you, the director, also for listening, like on their behalf, because as much as they may have walked out, you listened, and you gave them that opportunity, so I'm sure that's appreciated.
What do you
So I'm
mean?
going to go into this meeting.
Where are you?
And just try to see where it is, and if anything
I'll
is
call
needs
you
to be
later.
raised up, I'll raise it up.
Yeah.
appropriately.
That's appreciated.
Thank you for being mindful of everything.
Take care of you.
So can you, Ryan, can you take the lead in scheduling your follow-up by the end of the
I'm
day
still
today?
working on this.
What were the thoughts?
I've tried to